Thank you for coming on to the monthly TVN webinar. This is today's webinar is going to be presented by Susan Baptiste and Michelle Coe of McMaster University, and it's on a scoping review determining the role of occupational therapy in the ICU, results of a knowledge synthesis project. As I said before, this is a monthly webinar where we highlight Canadian and international experts and who can share their research and insights on advancements in assessing and caring for the frail elderly. In the past months, we have been highlighting the outcomes of TVN-funded knowledge synthesis grants, and today's presentation is no exception. This will continue on over the summer months, and then as we get on over the fall, we're going to be conducting webinars on the results of some of our other research projects that we have funded. And as always, we are planning the webinar series for 2016. We are subscribed to the end of this year. And if you have any ideas as to a webinar idea or something that you would like to see presented, please highlight it for us or send it to us, and we'd be glad to consider it. But without further ado, I'd like to introduce today's presenters. First is Susan Baptiste, who is a full professor in the School of Rehabilitation Science and Faculty of Health Sciences at McMaster University, with an associate appointment in the Department of Psychiatry. She completed her professional program in occupational therapy in England and her Master's of Science from McMaster. She is the former president of the Canadian Association of Occupational Therapists and vice president of the World Federation of Occupational Therapists, and she has worked on a team that developed a Canadian occupational performance measure and outcome measure used in over 35 countries. So highly experienced background to be presenting this webinar. And the other presenter is Michelle Coe, who is an assistant professor in the School of Rehabilitation Science at McMaster. She's an adjunct assistant professor in the Department of Physical Medicine and Rehabilitation at Johns Hopkins. She holds a PhD in health research methodology. She's a clinician scientist and who continues to care for patients as a physiotherapist in the ICU, and she is leading a clinical research program for early in-bed cycling in mechanically ventilated patients to improve patient outcomes, and we have collaborated with in the past, and it's also a pleasure to have Michelle presenting today. Before I turn it over to Susan and Michelle, just a quick item. Please submit your questions online during the webinar. This is to avoid interruptions, and we'll answer as many questions as possible immediately following the presentation. If there are questions that we don't get to, we can certainly try to post the answers afterwards. This webinar will be posted on the TVN website. It will take a few days for the webinar to be posted, but if you want to refer back to it, or if you have people that could or know of people that could not attend the webinar, please have them. They can go on the website. So without further ado, I'll turn it over to Susan and Michelle.
Thank you very much, John. That's a very generous welcome, and we appreciate it. I'm just going to check in that we can be heard okay. I trust we can. I can see little green buttons going up and down, so I'm sure that means the sound is okay. This webinar is going to provide us with an opportunity, hopefully, to open some dialogues with some of you, or all of you potentially, around the work we did and what could happen in the future, now that we have a bit of a foundation and a grounding on what exactly is going on out there where occupational therapy is concerned in the intensive care unit environments. Michelle and I were fortunate to be part of an incredibly good team that included students at all different levels. For example, Alex, a study retrieval, was very much an incoming student to our professional programs. Marissa, Jennifer, and Noreen were all recent graduates of those programs and from the Rehab Science thesis masters. Working with Michelle, for me, has been an exceptional opportunity. As I'm headed out the door in the sunset soon in my career, she's sort of doing the upward trajectory at the time. Mark Duffett is funded by a CIHR fellowship and is a pharmacist and works with pediatric ICUs. So again, the richness of that group was unbelievable. We're hoping then today just to give you a bit of background information about how this all came about in the first place and a reason why we chose this particular approach to move forward. Then present the research question and the methods with some of the results that we have available, considering the active OT roles as of this moment in time, some summary of the original research of active OT roles, and then the results that are related more particularly to potential OT roles that we foresee that are indeed opportunities that are down the road for us to work on from this day forward. Then hopefully we would love a discussion. We come from McMaster, and McMaster is renowned for interactive learning, and so having people talk back is really a blessing for us. So we'll look forward to that, and we'll provide a summary and some idea of where we think our next steps might be. So background and rationale. Michelle has been doing a lot of work with in this area, so I will give it to her to talk about that in detail.
Okay, thank you, Sue.
You're welcome.
So this has been a delightful project to work on as well, because when I was working in the ICU in Baltimore and occupational therapists were so involved in providing care, it seemed to me that there were lots of other opportunities for us to understand additional contributions that these occupational therapists could make to improve the care of our ICU patients. So I wanted to give you an idea of what the ICU environment is like. Here you see a picture of a patient who's in the ICU. And if we look at someone like this, we might think, they're quite sick. If you look at the patient's mouth, they have an endotracheal tube or a breathing tube. Just above the patient's head, you'll see that there is a screen, and that's a screen for mechanical ventilation. You can see that the patient's eyes are closed, and the patient is resting in bed. And this is an environment that can really be critical to help someone stay alive. But as we're trying to keep someone alive, we also need to think about what happens after the ICU. So why is rehab in the ICU important? We've gotten a lot better at helping people survive their ICU stay. We're learning, though, that surviving isn't enough. We've learned that in older patients, particularly the focus of TVN, older patients develop new physical and cognitive impairments after the ICU. We know that from a rehab perspective, physical and occupational therapy that started in the ICU can help improve functional independence at hospital discharge. However, we also learned that, unfortunately, these types of therapies are often underprescribed in the ICU. And this is critical for us and critical for TVN because by 2026, we know that the anticipated need for mechanical ventilation for people over 60 years old in Canada will increase by 105%. If we're getting better at saving people after the ICU, then we need to get better at caring for people after the ICU. So what does this look like? After the ICU, we know that survivors are at risk of developing physical disability, psychological distress, and cognitive dysfunction. Here's a landmark study that was led by Margaret Harridge in Toronto with the Canadian Critical Care Trials Group. She looked at patients who were in the ICU who had survived after acute respiratory distress syndrome. What they did was that after patients were admitted to the ICU, He looked at things like a 6-minute walk test, which is quite common in the rehab world, but not so common in the ICU world at that time. What this group found was that a 6-minute walk test, which is a measure of walking function, was impaired after ICU stay. She measured this up to 5 years later, and you could see that 3 months after the ICU, 6-minute walk test was 49% that of predictive age and sex-matched norms. But even 5 years later, patients who had survived their ICU stay were still 1/4 below that of age and sex-matched norms for walking. If we start to think of psychological distress and cognitive dysfunction, this is a similar study that was led by Dale Needham in the United States. He looked at respiratory failure ICU survivors in 41 US ICUs at 1 year. He looked at physical function, but also started to look at physical, psychological, and cognitive function, quality of life, and employment status. What's important to note about this cohort is that the mean length of stay in the ICU was only 2 weeks, and the hospital length of stay was about 3 weeks. So if we were looking at these data at 6 and 12 months later, and the middle column being normative values, we can see that from a physical function perspective, at 6 and 12 months later, physical function is about 30 points below that of age and sex-matched norms, and this is showing poorer function. You can see that for mental health, at 6 and 12 months later, we're looking at about 10 to 12 points below that of age and sex-matched norms. But what's most concerning is that patients who survive the ICU stay, 1/4 of them have developed substantial post-traumatic stress disorder. And this is something that we're hearing about in the people who are serving our country in the military, and something that we need to be concerned about for our ICU survivors. Moreover, just over half of people who were in the ICU were back to their jobs 1 year later. And finally, if we think of cognitive function, it's certainly an area where occupational therapy has tremendous expertise. This is a prospective cohort study, the BRAIN study, that was led by Maripande and colleagues out of Vanderbilt. If we were to look at cognitive function in patients post-ICU, 3 and 12 months post-ICU, with a very short ICU length of stay of only 5 days, you can see that these cognitive function scores that were measured by neuropsychologists, if the green bar represents normal and anything below that green bar is worse, we've got some concerns. These 3 panels represent 3 different age groups. And you can see that on average, at 3 and 12 months post-ICU, patients are presenting with mild cognitive impairment. This is not different across age groups less than 49, between 50 and 64, or greater than 65, or across time points. If we look at other measures, some people are presenting with scores that are consistent of someone with traumatic brain injury, and some are presenting with cognitive function that's consistent with someone with Alzheimer's disease. So these are the sequelae of being in the ICU, and things that we need to be thinking of to see whether or not we could try to address or improve these things. So we did this scoping review to understand how we can help these patients a bit better.
Yes, thank you very much, Michelle. That provides a very rich profile of what's going on, and also a very worrying one in many ways, I think. We took on this study and we designed it to address, to determine the state of knowledge regarding the role of OTs in the ICU. We really did not have any idea. And to determine the potential for expansion, or else also enrichment of the roles and the contributions that OT can give in the ICU. So the research question was clarified as, what are the reported roles and potential contributions of occupational therapists for patients in the critical care setting? Now, occupation is what? Everything that we do every day that is meaningful and purposeful to us and or is essential to health and well-being. If you consider what you've done since you got up this morning, every one of us have been engaged in many different kinds of activities and many occupations. For example, going to work, making sure that we're clean and presentable to get there, walking the dog maybe, feeding the family. And the roles that we fulfill are multiple. Everyone's life, while engaging in very similar things, is totally unique in the way in which that engagement occurs. So making and partaking in a family meal is a major occupational component that most of us either relish or will put up with if it means the kids are coming home from university. The tasks are cutting vegetables, getting out the sausages, lighting the barbecue, whatever it may be. The activities, which are a slightly bigger bunch of tasks, are like making the salad, barbecuing the sausages, and preparing the table. And the occupation itself is eating the meal with the family. So you can see a taxonomy there gradually developing. And our clients that are in the ICU are very often stuck, and often very unaware that they are stuck, at that level of very small tasks. So occupation is everything that people do every day that is meaningful and purposeful and essential to health and well-being. And occupational therapy is the art and science of enabling engagement in everyday living through occupation. We look at three elements, and when I say we, I'm talking about occupational therapists quite broadly, but particularly in Canada. My work at the World Federation leads me to know that, in fact, many countries follow this same principle and model, and most people are aware of it, as we are aware of other models that are used by the United States, Scandinavian countries, Australia, Britain, and so on. So OTs are highly trained healthcare professionals. We're using a very systematic approach that is based on evidence, best practice, and critical thinking and clinical reasoning. We provide assessment, intervention, and evaluation, and we consider the interaction of the person, the environment, and the occupation. So it's someone doing something somewhere. And when you think about that, it's all of us all the time. The piece that overlaps in the middle is occupational performance and engagement. So that is the piece that we focus all our efforts on enabling and ameliorating if there are issues. Taking a bath, for example, if we follow the same kind of analysis as we used when we were talking about preparing lunch, what do we do when we're going to take a bath? Well, it's not an easy thing to do, actually. We have to make up our minds that we're going to go and do it. We need to take our clothes off, put our robe on, get to the bathroom, however we manage to do that. We have to fill the tub. We have to get all of the accoutrements together so that we have our towel and our soap and our shampoo and everything else. We have to get into the tub, either sitting, standing to have a shower. I mean, I can go on. So even though OT may sound, well, it's not rocket science. No, it isn't. But it is everyday natural doing that so many people lose the ability or even the will to participate in following an experience as the intensive care unit. So when we looked at our definitions, the reported OT role was deemed to be any therapeutic activity currently performed by an occupational therapist in the ICU. And the synonyms included active or actual roles. The potential OT role, on the other hand, is therapeutic activity performed in the ICU that falls within an OT scope of practice and is not explicitly or necessarily performed by an occupational therapist. So things, you will see as the data unfolds what we mean by that. So I'm not going to take that surprise out of it. And Michelle, over to you.
Thank you, Sue. So it's been such a fantastic opportunity to work with everyone because we've had a multidisciplinary team. Many of us have different backgrounds, and part of my background is as a research methodologist. And we applied traditional scoping methods, scoping review methods, and systematic review methods to do this review. So we looked at several different databases from inception to November of 2013. And we worked specifically with an academic health sciences librarian to develop unique searches for each of the different databases. The general search string included intensive care unit plus occupational therapy. We used an extensive list of different synonyms and database-specific mesh words and keywords. So what did we include? We included any published report that mentioned active or potential OT roles in direct interventions with adult patients in critical care. We were very broad in the different types of documents that we included. So we included everything from original research, review articles, both systematic and narrative, guidelines, editorials, and commentaries. And because of the timing limitations with our funding with TVN, we restricted this to the English language. To sift through all of these different pieces of information or citations, we had an interdisciplinary team of 3 occupational therapists, a PT, and a methodologist. We did a review of titles, abstracts, and full-text articles independently and in duplicate by pairs of reviewers. And we resolved discrepancies by consensus. What was really interesting around this process was, as a scoping review, we had a lot of iterations and meetings around trying to understand the role and scope of occupational therapy, but also understanding the role and scope of critical care. So these were very rich discussions to refine our inclusion criteria. Once we identified the eligible citations, then we had a group of occupational therapists define specific interventions that would be within the occupational therapy scope. We abstracted data on the different on the publication. So where did the publication come from? What type of document was it? What the role was, whether an active role was something that was done by an occupational therapist, or a potential role, which is something where an occupational therapist could augment or contribute to the patient's care. We identified methodological details, and we also looked at different outcomes and recommendations. Again, all of this was completed independently in duplicate by an interdisciplinary team, and any discrepancies were resolved by consensus. So what did we find? I think that when we presented our results at the TVN conference, we had identified the most citations of all the other scoping reviews. So we identified just over 32,000 potentially relevant citations. We screened just over 3,000 abstracts, and remember all of this was done in duplicate, and we identified, retrieved, and read over 1,100 full-text articles. We ultimately included just under 400 articles, of which just under 100 reported an active role of an occupational therapist in the ICU setting, and just under 300 where we identified a potential role for occupational therapists' contributions. What does this look like? If you look at this graph, you will see that the x-axis represents the year of publication. The y-axis is the number of documents. In gray, we can see the potential of occupational therapy roles. In yellow, you will see that there are different types of publications or citations that report an active role of occupational therapists. And if you focus in on blue, there's a nice cohort of original research that's starting to emerge, with the first original research reported in 1986. We can see that active roles were reported in studies that occurred from mainly the United States. You can see the contribution of North America, but also Europe and Australia. And Sue, I'll invite you to pop in and make any other comments as we go through these results.
In fact, I love this slide. It's simple, but it's incredibly powerful because we did not realize, I certainly didn't realize, even from a global perspective, that there was work being done in other countries around the world, and many, since I did find that out, who are interested in engaging in it. So it really opened up a few doors for us, which was great.
And we'd like to acknowledge Mark Duffett's contributions to developing these result slides for us. He's very talented in helping us understand the key points from the data. So what types of publications did we find? We found a lot of review articles. And a lot of review articles, almost 60%, reported an active role of an occupational therapist. 20% was original research, 13% were editorials, and about 8% were others. What I'm going to do now is focus a little bit on the different types of journal audiences. So by journal audience, we mean who was the journal targeting? And we found that the majority of the journals were physician-oriented or medical journals. There were actually very few journals which talked about an active role of occupational therapy in rehab or OT itself. And it's interesting that there's a discussion of the role of OT more in a PT journal than there is an OP journal.
And that was really telling to me, because when I look at the whole notion of the occupational therapy evolution as a profession in Canada anyway, and in Britain, it very often is the case that people who are out there say, you know what, we've got a real hole in this team, we need a so-and-so. And for some reason that has to somehow be dealt with, OTs don't get there first.
And you'll probably then find this slide interesting too, is that the majority of the journals were actually critical care journals where we found a discussion about the role of OT. In fact, rehab journals only accounted for about 12% of the contributing journals.
And that was more than interesting though, Michelle. That to me was a critical piece of information that we were lacking prior to this project. Because I would never have assumed that half of the active roles were actually going to be reported in that kind of journal or publication.
Well, I think part of that also reflects, though, the multidisciplinary nature of critical care. I think critical care is very teamwork oriented, and once we find something that we think is going to help our patients, then we want to try to see how we can do that. How can we start to bring rehab into the intensive care unit setting?
It also pinpoints for me the dissonance between the perceived culture of an ICU and the actual culture. That for those of us who aren't within it, it seems a very distant and mystical place. Whereas for when you're in it, it's busy, messy, dirty, noisy, and please come and help and do this. If that's in your scope of practice, we'd love you to be here. And that, to me, was a very surprising message.
So then you probably found this next slide surprising as well. So what sorts of interventions were reported by OTs, what sorts of contributions were OTs providing in the ICU? So the majority of the studies reported more than one intervention. And you can see here in this slide that the majority of the interventions that are provided by OTs related to mobility, physical activity, physical rehabilitation, and activities of daily living. There were other contributions towards cognition and delirium prevention, not as much in terms around mental health and psychosocial contributions. How does this fit with you?
Yes, and you see, again, I think it really connects to the perceived role of occupational therapy, where people see OTs in a way like a mini physio. And it's the general rehabilitation role that is being responded to here, and it's an essential one. By no means am I minimizing it. But the actual potential scope of OT is not recognized yet. So we need the opportunity to explore it and to expand it so that people can appreciate the value added.
So we talked earlier about the multidisciplinary nature of ICU, and ICU certainly is a team sport. So what you can see here in this slide is who performed the intervention. Very rarely was it the occupational therapist alone performing the intervention. Oftentimes, it was the team of occupational therapy and physiotherapy to working together. However, you can see that outside of that relationship, occupational therapists liaise with several different team members in the ICU, including nurses, respiratory therapists, speech pathologists, dietitians, psychologists and psychiatrists, pharmacists, aides, and others.
Yeah, and that to me actually was very gratifying, because you could really appreciate then how much expansion there, how much room there is for expansion, and to get through that purple piece there. What is actually going on in there? We don't know that yet.
So let's talk a little bit more about the original research. In the original research, of the 98 citations, 20 were represented 17 unique studies and just under 1,400 patients. The majority of the original research occurred in the United States, and only 12% of the studies had an author who was an occupational therapist. There were 23 instances where authorship was unclear, but likely there was not an occupational therapist as an author.
That to me is a mystery, because I know you found out right at the beginning of our conversation and our relationship, you pointed out to me a situation where in fact there was one of the leading studies about OT contributions in an ICU. There was no OT in sight, and it was a very leading facility that had produced this research. So what happens then, I wonder? What is it that the OT does the OT believe they don't have time to write an article? I mean, I'm being a little bit frivolous, but not much. Why aren't they engaged? That is our problem as a profession, not anybody else's. But it has immense implications for enhancing the role of OT overall.
The original research occurred primarily in medical ICUs, neuro ICUs, med-surg ICUs, and across the continuum. And I think these different settings represent a lot of different areas where occupational therapists make contributions.
Yes, absolutely.
So if we were to look at the different types of study designs, how does this play out? Well, what was really exciting, I think, for us is that we found 2 randomized trials. There were 2 cohort studies, a few case series, some before and after studies, case reports, some surveys, and a financial model. And as we discussed, this represents just under 1,400 patients. Really exciting to see that this research is out there, that we're trying to understand, using rigorous study designs, potential roles and contributions of occupational therapists.
Yes, and that to me was a surprise, to be honest. I was very pleased when we got the RCTs. It was like a party over here, because we didn't realize they'd be out there, but they were, and they were pretty darn good. I mean, they were good models, so we were very pleased about that.
So why don't we talk a little bit about the RCTs then?
Yes, why don't we?
Okay, so for the rehab people in the group who are working in the ICU, you'll be very familiar with this study. It's a landmark study that came out of Bill Schweikert's group, Bill Schweikert in Chicago. And what they did was, in a medical ICU in 2 different centers, patients were randomly assigned to receive daily interruption of sedation plus early occupational and physical therapy 7 days per week versus standard care. What was really nice about this study is that they were thinking about outcome. And in this study, the primary outcome was independent functional status at hospital discharge, which was the ability of patients to be able to do 6 different activities of daily living independently, plus walk on their own. And what's great about this is that the people who received the daily interruption of sedation and early occupational and physical therapy more were functionally independent when they left the hospital. This doesn't surprise us, but I think it's very exciting for our field.
And I also think the other piece of this is it's not necessary to unpack which OT bit and which PT bit happened. When you're looking at a partnership like that, at that stage of care, it is enough to know that the bottom line is it made quite a large difference.
Very much so. And if we were to look at what was it really all about? It's about starting to receive therapy while on mechanical ventilation. So for those of you who aren't as familiar with the Rehab acronyms, this is our alphabet soup. P representing passive range of motion, progressing to active or active assisted range of motion, ADLs, activities of daily living, transfers, and walking. And really the important thing to note about this study is that it's about starting to receive the intervention early, within a day and a half of being on mechanical ventilation compared to the control group. The other piece to take away from this study is that it's starting early and starting to receive therapy while patients are receiving mechanical ventilation. And this 0.32 hours of therapy really translates into 20 minutes a day. But are we preparing our students to care for patients this early in their care trajectory as we're teaching them through our different programs?
Yeah, absolutely.
So the other study that I'll talk about, if someone can start to receive therapy early in the ICU within a day and a half and they can be awake, what about cognition? And here's some great work that's coming out of Vanderbilt, led by Nate Brummel. And what they did was they randomly assigned patients to three different arms in this pilot trial. And the pilot trial included cognitive therapy plus early PT alone, or usual care. And this was done in a med-surg environment. The primary test was the Tower test, which is a test of executive functioning, or the ability of someone to be able to reason through different cognitive tasks. And if we look at the Tower test, what's important to note is that there's no difference at 3 months post-ICU. But this is something that should not be discouraging for us right now, because we need to remember the context in that this is a pilot randomized trial. Cognitive therapy could actually be started within 2 to 3 days of being in the ICU. Mm-hmm. So if we think of that gentleman who we first looked at the beginning of this talk, mm-hmm. if we can wake them up, if we can start to move with them, we can also start to engage their brains.
And if we also engage their environment in the process. So we're looking at the sensorium as well. You know, what sort of sounds are familiar and peaceful to this gentleman? What kind of music did he like? What kind of, all sorts of inputs that one could have into his world that starts to create memories of normalcy.
So the last study that I'll highlight is a financial model. And this is some great work that has come out of Johns Hopkins with Dale Needham and Robert Lord, who's now in med school at Hopkins. They did a financial model to look at the effects of adding early OT and PT as part of usual care in patients who are receiving mechanical ventilation. And this slide highlights the difference in length of stay in the ICU with additional resources of OT and PT for patients. And you can see here, length of stay dropped from 6 days to 4.7 days. After the resources of OT and PT were removed, length of stay actually went up to 6.5 days. But in 2009, they started their sort of world-class early rehab program, and the length of stay went down to 5 days. And this has continued to maintain over the course of this particular time period. Mm-hmm. And as we're trying to think of ways that we can help improve our healthcare for our patients, you can see that the graph looks quite similar for length of stay in the hospital. And using this financial model, they projected a net cost savings for just over $750,000 for 900 admissions per year, a 22% reduction in ICU length of stay, and also 19% reduction in floor length of stay.
Mm-hmm. That's pretty dramatic, and that language most everyone understands.
Yes. The challenges of this research, though, is that this was conducted in a medical ICU, which is more common in the US, whereas here in Canada we have medical surgical ICUs. So trying to remember that some of this evidence is specific to medical patients is a bit more of a knowledge translation challenge in the Canadian environment.
And actually, do the results from this study, Michelle, pinpoint the difference between the two populations or not?
It's a really good question. So we haven't yet studied medical patients exclusively. In fact, I think we need to do studies in Canada that best reflect our care environments, which is more of a med-surg ICU.
Yeah, absolutely. Okay.
So what about the potential role? If we were to look at the original research, we can see that the majority of the evidence is from the United States. There are 2 RCTs, which I think is really exciting for the field. There are potential important utilization savings from a financial modeling perspective. But as we discussed, there's minimal occupational therapist representation and authorship in this field.
Mm-hmm. Yeah, which we really do need to pay some attention to.
So what about the potential role?
Here we go.
This is the fun part. So what we did was, you'll see that we have mapped the actual role against the potential role. And the actual role or active role you've already seen. And these are interventions where we thought that occupational therapists could make a contribution. Mm-hmm. So in gray, we identified opportunities that are perhaps a little bit different from what we're actually seeing right now.
Yeah. And probably we minimized in some ways in our brainstorms the obvious inputs of rehabilitation techniques in general, in a more generic sense, as well as the more traditional inputs that people have expected. So I'd like us to start looking a little bit around the issue of delirium prevention and care. This was an area that when we started off, our own private hypotheses were very strongly in that direction. We had made assumptions that in fact there may well be OT input to cognitive assessment, intervention and delirium prevention, when in fact very little of it existed. Seating and wheelchair or alternative seating in general was there, but it wasn't there as much as we thought it could be. Augmentative and alternative communication didn't seem to be the bailiwick of the OTs. Although OT and speech and language pathology work very closely together in any other medical environment to address these issues. Environmental modifications and adaptations were sorely lacking. And this was not perceived in any particularly powerful way through the literature as something that really was being considered. Now, when I got first interested in this area, one of the things that drew me to it was because I am very interested in organizational cultures, very interested in the literature about the changing culture of the ICU. And so when I was reading those articles, I was thinking exactly, it's the environmental piece that has been so sadly minimized in the past. And this is largely where OT can become extremely helpful in making those kinds of adjustments and enrichments. Assistive devices, again, very traditional, not necessarily particularly helpful. I mean, the OT's common nightmare is having to hire a truck to get a patient home because of all the stuff they've been given on the way through. There are some, but not to necessarily make that a major role of the OT. Mental health and psychosocial interventions were mentioned very little, and this again is a huge component, especially when you look at the person integrated within the family or circle of care, that the OT role was never very much involved in other elements of that person's life, like families, wives, spouses, children, grandchildren, etc. Feeding, eating and swallowing, important, but already in place in large part, as is splinting. I mean, very often the natural reference for OT to get into the ICU is we need a splint. Discharge planning, a little bit, but we perceive that should continue. And skin care. I was certainly surprised to see there wasn't very much of that there, because I had assumed there'd be more. But family support and appropriate intervention, as I've just mentioned, very key. Mental health, psychosocial intervention, we've got that twice. It just shows you how important we think it is. Education. Education of whom? Both patients and families, about what's going on and what could be done to make life a little fuller. Sensory stimulation is in existence. Writing diaries, looking at reflective journaling, helping the patient to explore their experiences of what was happening to them. And part of that really was deemed to be important when we looked at the PTSD component of one of the studies. That was a huge surprise and a very unfortunate one in my mind. Music therapy is all over the place, but again, OT uses it quite a bit to create a calming and enriching environment, but OT never was included in the past. Other is a bit like a dog's breakfast, a little bit of this and a little bit of that, and we won't go into it today in the interest of time.
So who was performing these different interventions? It's probably not surprising that nurses, who are really the ones who are with the patients day in and day out, have been the creative ones to identify this is what the patients need. Physiotherapists have also been involved in providing the interventions as well as others. Again, if we were to look at the journal focus, we can see that the majority of the documents are occurring in critical care journals with very little representation in rehab journals. And similarly, with the journal audience, we're seeing that for the potential roles, we found a lot of the literature in the nursing literature, very little representation though in rehab, and some representation in medical journals.
And in potential role, there was no OT at all.
Mm-hmm.
Yeah, which was very interesting to me, especially at this time in the evolution of the profession, when in fact role emerging opportunities for investing in environments is very high on the list. So that was a real surprise to me.
So we're going to go through a few slides and just talk about sort of the last little bits in our last few minutes as we wrap up.
Yes. So do the reported roles in the ICU reflect the optimal use of an occupational therapist's expertise? Well, I guess it isn't too much of a leap for you to know I'm going to say they certainly do not. There is a huge amount of potential here, and it's something that we have already begun conversations with colleagues in Toronto, other parts of Canada. The OT National Conference has just been passed, and there's a buzz about this. Of the reported roles then, where are occupational therapists likely to have most impact? And most of it is in more of the traditional rehabilitative roles, plus some of the newness that we have just referred to in the last 4 or 5 minutes of this talk. There's more to come, and I would love to get a little bit of discussion going if we do have some time in a minute. The limitations of this study, of the original research rather, is how was it described? And always it seems that it was described as excluding, and this study was fascinating because Inglas was it's a surprise to me that this is what was said, that OT interventions were defined specifically as excluding interventions that exclusively involved only splinting, bracing, passive positioning, etc. I can appreciate the purpose of that was to get rid of the generic rehabilitation inputs. But on the other hand, if this is what OT was doing, we needed to balance that with other interventions that potentially could be added to enrich that particular role at that time in that facility. So what are the research priorities for the potential role of OT in the ICU? We've certainly talked a lot about that, haven't we, Michelle? And I would love to get a broader picture of what is going on across Canada now. What kind of resources are in fact enabled to participate in OT roles in ICU environments, and what do those roles contain? What are they comprised of? We don't know that yet. So that kind of survey, I think, would be extremely valuable. At the same time as which, and I don't see the survey has to happen in isolation, there can be parallel paths for inquiry around, so when the roles are involving something else, for example, locally, we have some hours put into an ICU role with augmentative communication and technology. Unusual, yeah, based on their literature review. So let's look more into that. Let's do some of these pilot studies that can show us what the enhanced roles actually can look like. So we had a multidisciplinary team, a very rich environment for creativity, a rigorous scoping review of over 32,000 of citations, original research, and really it isn't a stretch to say yes, OTs can make important contributions to ICU recovery. And although current contributions are primarily mobility related. And there's tremendous potential to augment current care and improve patient outcomes. So that's the invitation. When are we going to get on with it, I suppose? What do you think, Michelle?
Well, it's been fascinating, and I think as a therapist, it's been so enriching to learn more about your profession, and I think that's the first conversation we had, was we have OTs in the ICU. I can see them making a contribution, but there's more. Help us understand more about how you're trained, what you do, how you can help our patients get better, because there's so much more that they need. And I'm not sure if we're optimizing what your contributions are right now.
We had an experience right at the beginning of starting this study, and that was we had a couple of students on a research project with me and another colleague, and they went and visited Michelle in the intensive care unit. Both students were pretty much almost deers in the headlights on their very first interface with the unit. But Michelle came out of it, and it totally voluntarily contacted me a couple of days later and said, I can't tell you how impressed I was with the way these young women approached the environment, what they suggested, what they did, and everything was sort of flying on the seat of their pants, so to speak. Mm-hmm. And that to me was a little conversation, but it was a very powerful one.
Mm-hmm. It was exciting.
Yeah, yeah. So, questions, discussion, please.
Hi, Sue and Michelle. That was a very good presentation. And we do have a few, we do have a few questions, probably more than you can answer, but I'll try to get to most of them. I guess one of the first questions that came up is, how are we going to get more orders for OT in the ICU based on what you're saying today?
Well, I think that's a huge question. First and foremost, education comes to mind. ICU environments need to have the opportunity to understand what the scope could be, and the OTs within a facility have the responsibility to market that role and, in a way, sell it. Mm-hmm. You know, it has to be a two-way street. If someone in a unit has a sense that more needs to be done and maybe this OT thing has got some potential here, then the OT also has to be ready to meet them more than halfway and say, let me show you. Give me a chance to come in there for a month and I'll show you.
I think it's a tough balancing act, depending on the hospital environment and how therapy is funded. I don't think that it would be suitable for everyone to have a blanket order for OT, just like they shouldn't have a blanket order for PT. If we're careful about the resources we have, would you see things that you would want targeted for a request for a referral for OT?
I would love to see someone putting into a referral, OT, can you please consult on this gentleman, so many years old, who is isolated in the ICU and comes from a very large active family. His physical situation is this, his therapeutic and treatment situation is this. Please advise and inform within a week or whatever. Does that make sense?
Mm-hmm. That does. So I'll get to one or two more questions, and this is probably because of your great presentation today. To improve OT authorship, would you be interested in collaborating with OTs across the nations? And if so, what would be the procedure to reach out to you?
I would be more than interested in collaborating with OTs across wherever. The best way to get in touch with me is by my email, so please go on to the McMaster website, go into School of Rehabilitation Science, and then look at the faculty list, and I'm on there, and my email connection is there. I mean, I'm happy to give it to you now, but if you've got a pencil, poise, but pencils are rare these days. Everybody's on, oh, maybe you're going to put it on your phone, I don't know. My email is my last name, Baptiste, which is Baptiste with an E on the end, at McMaster, M-C-M-A, at McMaster.ca.
I think that highlights, though, an issue for clinician scientists in rehab period. There are very few scientists who care for patients in the ICU and conduct research. So we do need people to have the clinical background but also have the research training to help move this agenda forward. We need, what's nice about being here at McMaster is having the occupational therapy program really embedded right beside physiotherapy, so we get a chance to work together and to start the scholarly inquiry, which we've done with this system, with this scoping review, to encourage more scholarly activity in the occupational therapy role in ICU.
Yeah, definitely. I mean, our offices are actually in a mess. I mean, there's a physio and OT, another physio and OT. We're all over the place. So there is no distinct silo for either profession. We're also expected to be engaged, actually, every one of us, in research and service. And so we make sure that we do that in an interprofessional way as much as we can. So I totally support what you're saying on that. It's nice to have a physio who understands the need to understand OT. And that is not necessarily a common state. And we have several here, which I greatly appreciate.
Yes, that seems to be a good combination. I have one more question for you, and this might take a little bit longer, but what tools do you recommend for cognitive and psychosocial intervention?
Oh, my goodness me. Yeah, well, we need a webinar on that.
There's a couple questions that came up that are very similar to that, so there must be a big interest in that area.
Yes, I am not prepared to give you a shopping list. I really do think we have to go back to the sort of the starting place of what is cognitive assessment, what kinds of cognition are we wanting to evaluate, and that we are wishing to develop a study around, which I think is really important as well. But when you're looking at the outcomes that you want someone who can engage more specifically with their home environment, if in fact they're going to be living at home or in their care environment, whatever. So how can we best assess them to enable them to gain those skills? I mean, it's a huge question. If you're looking at mental health, you're looking at question of the ability to external, internal locus of control. How much does that patient actually accept and engage and own their own destiny? I'm sounding a bit like some fairy tale. That's not what I mean. But it's a huge range of things.
And I think some of the challenges that we need to think of are how do we adapt it for someone who has varying attention span, because they may or may not
Absolutely.
be delirious, who might not be able to communicate because they have an oral endotracheal tube, who might be very weak. So there's a lot of opportunity
Absolutely.
to be creative, and I think one of the students that shadowed me for that day, she was be able to look at the patient's ability to orient themselves to date and time.
Mm-hmm.
And it was simple, it was elegant, but adapting what the patient needs at that time,
Yes,
that moment.
Yes. Yeah. So again, it's very much a give and take. I think, in fact, that question could be broken into 2 or 3 really excellent projects. Because we may think that we've got our favorite assessment, but when you're in an ICU, that really isn't the one that it should be used. So, yeah, well, I love it. I mean, that's got me thinking now. I think we've got, is everybody gone?
No, everybody's still on. I think it's back to John. I think we're almost
There
at
was
the
a
end of our
silence.
time.
You never know.
I think you need to do a webinar number 2. You've had lots of questions, and we can't get to them all today, but I'll pass this along to John, and he'll just put the last comments on today's webinar. So thank you.
Thank you, Carol, very much.
And I'd like to also add my thanks to both presenters. It's been a very informative and enlightening webinar, and judging from the number of questions, a lot of interest. And I think this type of knowledge synthesis and scoping review serves to highlight areas where we can improve practice, but also areas where we can do further research to improve the care to our patients. And I think this type of webinar has done both things. So in addition to thanking the presenters, I'd like to thank all the participants in today's webinar. We're very grateful for you taking the time out of your busy schedules to come online, and by disseminating knowledge this way, we hope to improve the care of the elderly, which is where we're focused. Just a reminder that a brief feedback survey will pop up on your screen within the next few minutes. Please take some time out to fill it out. We value your feedback, and we'll use your feedback and your opinions in improving the webinar series. And please continue to tune in on our webinars. Our next webinar is on the first one, is going to be July 8th at 12 noon, and that's going to be a scoping review of hip fracture quality indicators by Susan Jaglaw at University Health Network in Toronto. Please follow us on Twitter. And as I said before, today's webinar slides will be available on our website within the next day or two. So thank you again to our presenters, and look forward to interacting with you in the future. And please visit our website often to look for updates on TVN. And I think with that, we'll end today's webinar.